Hello and welcome everyone. We are going to start shortly as soon as Professor Goel joins us. And again, thank you very much for your interest in the series. It's an honor to host Professor Atul Goel, who is really a huge inspiration for all of us globally. So I'm really honored to, welcome him shortly. So just waiting for it to start. Thank you very much. Stay tuned. Hello, sir. Welcome. So good to see you today. Sir, can you hear me?
Oh, no. Yeah, Noor, hello, how are you?
I'm great today. Thank you very, very much, sir, for joining us today. I'm just actually setting my camera. I will turn it on shortly.
Okay. Thank you, Noor. Let's do it. Let's do a beautiful show and let's be happy. Okay, Noor?
Yes, exactly, sir. I'm always so happy to welcome you. You are such a huge inspiration for all of us globally. And I remember the time when I joined neurosurgery. You were one of the first neurosurgeons I came to know about, and you were like an inspiration to the very start.
Thank you. Thank you. Thank you, Noor. And
You have
everything.
brought a lot of happiness for all of the neurosurgeons globally. Yes, sir. Exactly, sir. And I was so much, I was so much happy to see that many neurosurgeons send a lot of messages for you. And, you continue to inspire us. You continue to, it's a huge thing. It's a very, very noble profession. And to share it and to educate others is such a noble deed. So we really respect you in that manner. And it's like we are one vote. For neurosurgery, we are one vote.
Of course. No question. No question. No discussion. No argument.
Hello, sir. Thank you very, very, very much again, sir. It's an honor. I'm so happy to welcome you again, sir. Thank you so much for joining us. And sir, the topic is very, very interesting, and I believe that it will be very helpful for all the neurosurgeons. Thank you so much, sir.
Thank you. Thank you, Noor. Let's do it.
Sir, would you like to commence the webinar now?
Whatever you say, you are the boss.
No, sir, you are the big boss right now. I'm just trying to. Okay, sir. So let's start the webinar from now. I think I just hit the record button. I'm going to just Thank you very much, sir. Okay, so I'm so much pleased and honored to introduce Professor Atul Goel to rather welcome him again in our series. It's an honor to organize a series with one of the masters of neurosurgery. When we came across his name, we might have been thinking about the CVJ, but actually he's much more than the CVJ. He can cover each and every topic, each and every aspect of neurosurgery, and either cranial or spinal. So I believe that you are such a big name, sir. It brings me like I become so much conscious to introduce you because everyone knows you so good, and I cannot find the right words to introduce you. So obviously, Professor Goel does not need any introduction. He's one of the leaders in neurosurgery. He's currently head of department, in the King Edward Medical University in India. We also have a KMJ in Pakistan. So he's in the India part of that. So, sir, thank you very much, sir. Professor Goel is going to talk on petrocrival meningioma. That's a topic of huge interest. And, one of the most favorite topics of Professor Louis Borba as well, who is the current president-elect of WFNS. So it's a topic of great interest, and I think it's you have selected such a wonderful topic because many of the people have a lot of questions and a lot of confusions for this type of tumors, especially the young generation neurosurgeons. I've been seeing that many of the people have some sort of they need a more concept and more clarity about these approach those surgical approaches for peritonial meningioma. So thank you very much. The floor is all yours.
Thank you, Noor. There's no question. It is my great pleasure. And whenever I talk on skull base, because skull base has been my life for so many years. I have worked in this beautiful subject. I have enjoyed this beautiful subject. and I will like to talk to you on this beautiful subject. Basically, petroclival meningiomas are the top of the line of skull-based tumors. As we know, petroclival. Can you see Noor, my slide?
Sir, I believe, yes, we can now.
Okay. So petroclival meningiomas are difficult tumors. Petroclival tumors are benign. Meningiomas are benign tumors. Petroclival meningioma surgery can give new, benefit of symptoms, and from all these things, patient can recover from all these problems. On the other hand, you can create devastation, you can create deficits, you can create huge deficits, and you can even kill the person. So it is very important that we understand petroclival meningiomas, we understand the nuances of skull-based surgery, and we understand the subject of neurosurgery in general. So this was one of my article where I said that neurosurgery is an amalgamation of philosophy, technique, and technology. It is not just, oh, I have removed this tumor, and you show preoperative image and postoperative image and this and that, very happy. What we have to do is we have to be philosophical. We have to use our techniques to the best of our ability. And wherever technology is there, we have to use the technology. Most important equipment in dealing with skull-based tumors is, of course, a beautiful, good microscope. May not be top of the line, but the person has to be comfortable with microscope. Second most important thing is the drill system. You have to have proper drill. You have to have burr, you have to have diamond burr. And more than anything else, you have to understand the anatomy of that area. So neurosurgery is an art. Neurosurgery is a concept. Neurosurgery is a philosophy. And I'm convinced from my experience over the years that if we create a deficit, we will think, oh, this is just sixth nerve deficit. Oh, this is just fourth nerve deficit. Oh, this is just facial nerve deficit. At least the person is moving his hands and legs. But these deficits just disable the patient. They completely demolish the person. And we should understand that patient may come with just marginal symptoms. So we are going to relieve the person of his symptoms, and we should not come out with creating huge deficits. I'm not saying deficits cannot happen in this operation. Deficits happen in all situations in neurosurgery, and this is one of the complex locations, and we have to understand that we can create a complication. On the other hand, we don't go to operate to create complication. We operate to relieve the person of his problems. So in general, we have to understand that all petroclival meningiomas are different like fingerprints. All fingerprints are different. Similarly, all meningiomas are different. Yesterday in one of the webinars, I was saying we identify a dog on his nose print. We must know that our pinna, our externally a pinna, every human being has a different, no two pinnas are similar. No two voices are similar, voices. No two cerebral sulci and gyri pattern are similar in two individuals. So everything, this difference makes life. Life is like that. So meningiomas are different, not by virtue of its size and location, but also consistency, vascularity, extension, difficulty in surgery, and more important than anything else, the ultimate outcome of meningiomas. So petroclival meningiomas may be, petroclival meningiomas are petrous bone and clivus bone, this junction. There is trigeminal nerve at the apex of the petrous bone, which goes in the middle fossa in the lateral wall of cavernous sinus. The tumors medial to the trigeminal nerve are usually labeled as petroclival meningiomas. So they may be small tumors, they may be huge tumors. They may be calcified tumors or ossified tumor. You see, this tumor is a different meningioma, different implication, different surgical style, different goals, but this is different. This is, you see, another calcification, extension in the petrous bone, basilar artery encased, cavernous sinus involved. So this is different style, different aims, different objectives involving the cavernous sinus, having calcification of various kinds. This tumor is another huge tumor, middle fossa. So petroclival meningioma essentially are in the petroclival area. But extension into the middle fossa, into the cavernous sinus is quite frequent because of the relationship. They are neighbors. So extension into the neighborhood, into the cavernous sinus, also into the nasopharynx. So when the tumor, in my estimation, when the tumor is multi-compartmental, goes from one compartment to another compartment, it is behaviorally little bit more aggressive. Like if the tumor is only in the middle fossa or only in the posterior fossa, they are behaviorally little bit different. When they are in both middle fossa and posterior fossa, they are behaviorally more aggressive. And when the tumor goes into the nasopharynx, it can be taken as an aggressive malignant tumor, and you can treat them as such. So these tumors involve cavernous sinus quite frequently, carotid artery quite frequently, goes into basilar artery, into the petroclival area. They can be right in the clivus. So all these tumors are labeled as petroclival meningiomas or tumors. And many a time they go into the cavernous sinus, they involve the entire clivus, they displace or encase the basilar artery, they involve the confines of the cavernous sinus. Sometimes they go just in the metals dural cave. Sometimes they go into the venous plexuses of cavernous sinus. So these are different types of, quite infrequently, they can be as vascular as this tumor. You see large vessels, large veins, and this was, of course, hemangioparasitoma, difficult tumor, dangerous tumor. You must know that tumor is dangerous, but the patient comes with the similar symptoms of headache and all. Patient does not know he is having he or she is having a dangerous tumor. Patient does not want to have a deficit. Patient does not want to have hemiplegia. Patient does not want to have facial weakness. So this vascularity and all is not for the patient does not know his vascular tumor. We have to understand and we have to prepare ourselves for eventuality and how to deal with such vascular tumor, how to control bleeding. So this is the petrous bone, this is the clivus. This area is petroclival area, very close to the cavernous sinus. And most important is very close to the trigeminal nerve and most close to the sixth cranial nerve. So whenever you do petroclival meningioma surgery, the most important, most critical, and most important nerve that is in danger is the sixth nerve. And both six nerves are quite in close proximity, and you can have both the six nerves in danger. So, surgery of petroclival meningiomas, you see, one is access route. In the access route, there can be facial nerve, there can be hearing nerve. If you're coming from middle fossa, there can be trigeminal nerve. And the sixth nerve, and also the tentorium, there is fourth nerve. So this is a dangerous tumor. This is nerves, but vessels, any single perforator you damage during dissection, you damage one perforator of basilar, you kill the person or you damage the person or create huge deficits. So this is a intensely dangerous operation, and we have to understand, and we have to understand from our experience, from our philosophy and our conduct, and we have to give a beautiful, good result to the patient. So petrous apex anatomy. So petroclival means all these tumors are in relationship to the petrous apex. So this is trigeminal nerve, this is gasserian ganglion, this is the region of cavernous sinus, this is the edge of the tentorium, this is third nerve, and this anatomy has to be understood very clearly, very fantastically on the basis of dissection, on the basis of cadaver dissection, and not just one dissection or two dissection, months and years and lifetime of dissection. There is carotid artery here in the petrous, there is greater superficial petrosal nerve or GSPN, there is facial geniculate ganglion here, and there is cochlea here, this petrous bone is without any neural or vascular structure, which is called Kawase triangle, as we all know. So we drill the Kawase triangle, we go into the posterior fossa from the middle fossa. So learning the anatomy, learning the art of drilling this area, protection of nerve, protection of carotid artery are so much critical and crucial. So I have been in this journey for several years, and you can imagine 30 years ago, I wrote this book with Professor Kobayashi, and the skull base part of tumor part was written by me. And you can imagine 30 years ago, and the beauty of this book, if you happen to read, this book is still available. The beauty of this book is the whole book, my part at least, is monographic, means I have not used any other reference except my own work. 30 years ago, I had that power to use only personal references. So that is the beauty of this. It is a monographic book. And you must read, I must get hold of this book. And if you see the cover page of this book, I was involved in drilling. And I used to drill, I conducted workshops, several workshops around the world, including Japan on so many instances, in China, in Singapore. Many situations I conducted. My first workshop in Japan, in Shinshu University, with Professor Kobayashi was in 1992, where I demonstrated how to use the drill and all those things. And you'll be surprised, when I was drilling and demonstrating, people behind me included Hakuba, who is one of the foremost in skull-base surgery and who described petrosal approach and orbitozygomatic approach, Hakuba, very famous neurosurgeon. The other person who promoted petrosal approach was Al-Mefti. He was behind me. Kawase, who has his approach on transpetrous apex approach. Kawase, and these pictures are still in my library, and they give me such great pleasure when I see Kobayashi was there, and Dr. Hongo, who have now retired, and Ohata, who was a senior professor and very famous skull-base surgeon. They were all there. So essentially, in my lifetime, I used to do a lot of petrous bone drilling, carotid. This is, you see, carotid artery displacement, trigeminal nerve displacement, and if you see the facial nerve mobilization and total petrosectomy, this approach was described by Dr. Laligam Shekhar, who was very prominent skull-base surgeon at that time, and of course still a prominent. And this was the approach which I used to do on a regular basis in my operation theater. Of course, not always, and indicated. So we modified our approach to an extent. So orbitozygomatic approach means orbitozygomatic. You use zygoma resection to pull the temporalis muscle down so that you get an additional exposure here. So we made an alternative kind of incision. This is a long time ago. I picture also of long time. And we did basal craniotomy. This is the root of zygoma. I didn't remove the, this is one of the approaches that we described more than 35 years ago. You must remember at that time, it was too long time ago. So this is zygomatic arch, root of zygoma, roof of condyle, roof of external canal, and we included mastoidectomy. So this was subtemporal craniotomy. And this inclusion of mastoidectomy in subtemporal craniotomy was first described by us in this paper, which I'm going to show. So root of zygoma, roof of condyle, roof of external canal, and mastoidectomy. So this was the paper, basal extension of craniotomy for subtemporal middle fossa approach, basal extension. So this is the subtemporal craniotomy, basal extension. This is the condyle, this is the roof of external aortic canal, and little bit of mastoidectomy we used to do. I'm not saying in all cases, but in many cases, and I described this approach. So this was the incision, this was the basal cut, this was the craniotomy. We also described 30 years ago this tentorial dural flap. My hook used to go from here, and the knife was placed on the edge of the hook, and I used to take like that and made a flap. And I described this flap in 1995. So this is you can see in 1999, I did 24 cases with this approach. This basal approach, this is the root of zygoma, this is the condyle, this is external ear canal, and if you see, this is the condyle, this is the external ear canal, and mastectomy. This was the extended lateral basal subtemporal approach for pictoclavian meningioma. I must tell you that I don't use such basal extension now. This is my history. I am saying how I had evolved during the period. Then in 1997, you see, this was the incision, and this was the temporalis muscle was rotated anteriorly. So this base did not come in picture, anterior rotation. Then what we started doing is we started splitting the temporalis muscle, splitting to get this basal exposure. So we could avoid the zygomatic osteotomy. So this splitting of temporalis muscle for basal exposure we described in 1997, I think quite a useful technique. And extradural approach, intradural approach, temporal retraction, yeah, height of neurosurgery, ultimate of neurosurgery. So only those people should venture into this, those who have tremendous anatomy, have confidence of sky, and precision and perfection like anything else, and more than anything else, confidence in your own self that you will not harm the person. Of course, you can harm the person, but confidence of not harming. Another beautiful approach that I described, which many people refer sometimes, like this is the greater superficial, this is the petrous bone, this is the facial nerve, this is the geniculate ganglion, this is the labyrinthine segment of the facial nerve, this is the geniculate ganglion, this is the tympanic segment, this is the mastoid segment, this is the geniculate ganglion, this is the greater superficial petrosal nerve. Parallel to this nerve is eustachian tube. Parallel to this nerve is carotid artery inside the petrous apex. So this is an important landmark in skull-base surgery, greater superficial petrosal nerve. There is middle meningeal artery also having a very close relationship with this. So this relationship has to be understood. So we described a technique where I cut the GSPN and then mobilize the tympanic and labyrinthine segments. You see, tympanic and labyrinthine segment to expose the petrous apex and widen the Kawase triangle. You see Kawase, and now you can drill the petrous apex. And so this was an extended middle fossa approach that we described and we used. And we described on a number of cases during that period of time. Then we used extended middle fossa approach for clavicle chordomas, for trigeminal neurinomas, and this is the extradural approach to cavernous sinus that we had described from the middle fossa, understanding the petrous apex anatomy, understanding the fifth nerve anatomy, understanding the sixth nerve anatomy, and understanding the cavernous sinus anatomy. That is understanding the anatomy. But anatomy itself is not the issue. You have to know how to control the venous bleeding. You have to know how to control the carotid artery, how to protect the nerves, how to dissect the tumor. And also you must remember when there is a tumor, the anatomy is different. Anatomy is not the same. When there is tumor, the anatomy is different. When there is no tumor, there. So altered anatomy. And you have to understand how the tumor will alter the anatomy. And trigeminal neurinomas, I will talk on some other occasion on this subject where my experience is huge and many of you have heard me on several occasions. I will give my lecture on this in the next situation. So petroclavial cavernous meningiomas, my approach was essentially middle fossa approach for a long period of time. And this meningiomas involving the cavernous sinus, involving the carotid, going anteriorly, this middle fossa approach was a beautiful approach. Now, 31 years ago, I did this operation. You see, this is the petroclavial meningioma encasing the basilar carotid. And this is my, like a trophy of mine. I like to showcase my trophy or flaunt my medal. This is my medal. 31 years ago, I did huge petrosectomy and facial nerve mobilization, cutting the GSPN and all those things, and mobilizing and beautiful. And this patient is still alive. And this patient refuses any further investigation. She was blind at that time when I operated. She continues to be blind. And when I asked her, how are you moving around? Now she's an old lady. She says she's still blind, but her children say that she's able to cook chapatis even now. And I said, how a blind lady can cook? So this was the beauty of nature and beauty of Mother Nature. So this was 1994. This was, of course, relatively straightforward. Middle fossa. I used this. At that time, young man, I was 35 years ago, 30 years ago, more enthusiastic, more dynamic, more using drill. And whether it is necessary or not necessary, my nurse would be ready with the drill. And these are my old cases during that time. You see, this case, I must tell you, this lady was a young lady when I operated, and I removed this tumor. This tumor I would never do in the way that I did then. I had mobilized the facial nerve and all those things. I'm talking of more than 30 years ago. This tumor I operated, and this small residue. Now, this patient came to me after 7, 8 years. She was married and she had 3 children during that period of time. And now all the 3 children are very huge and burly children. But this lady had a recurrence of tumor. I reoperated on that tumor, but she did not survive. So this is the fate. These tumors are histologically benign. Most important is, as I have said, nobody can predict which tumor will recur or which tumor will not recur unless there are typical histological parameters. So this was another tumor in a very famous custom clearance agent. At that time, I used to go to Japan very often. This lady used to help me in bringing my cameras and my video recorders and all those things. And this was the case. And recently, after more than 30 years, she died of multiple myeloma. So these tumors, you you operate, you remove, and you give new life. Question is, you can harm the person also, and that we have to understand. We are not gods, we are human beings. We can create six nerve deficit, we can create neurological hemispheric deficit. This was another tumor. You see, there are two types of meningioma and two histological, two types. So this was syncytial type, this was meningiomatous meningioma. So these two meningiomas in one meningioma. In general, tumors which involve the cavernous sinus are histologically more aggressive tumors. And this was another tumor which I operated several years ago, maybe 1999 or 1998. And this patient developed severe hemispheric deficit, hemiparesis. And this changed my life after this operation. You can see a beautiful resection so many years ago, but developed hemiparesis, and that changed my life. And I realized that how to save the perforator, how to be at the safe distance from a perforator, how not to handle the cranial nerves more. Now my policy is, if I have to dissect and handle the cranial nerves for more than 10 minutes, I will leave that tumor behind. If I have to dissect near a perforator for more than 4 or 5 or 6 minutes, I will not dissect. I will leave the tumor behind. I will not take the risk. And this information was given to me by this patient. He's still alive, this guy, but has hemiparesis, but he's able to conduct himself. This lady, another one, somebody had tried to expose this tumor. He removed the temporal brain. So the whole thing was, when I did, was open for me, directly hit the tumor and removed. And this patient had developed hemiparesis much before I touched and much before I handled the tumor. So these tumors can be, I used to do middle fossa approach on a regular basis. This tumor, my indication was middle fossa approach. This posterior clinoid meningioma and pictoclavial meningioma, my approach was middle fossa approach. And not only this is anastosis of the posterior clinoid. When there is anastosis, the tumors are more firm and more gritty and more stuck to the adjoining vessels, more dangerous and more difficult. This was another pictoclavial kind of meningioma. This was another in a very prominent person where I removed and I left some from the middle fossa tumor. To go down to the pontomedullary junction can become difficult even if you have a big exposure. So there was some residue here, but there is, at that time we never used to talk about any gamma knife or anything. Even now, I don't like to talk too much about gamma knife for residual tumors, but that time there was no question. So this patient, I don't know what has happened to this gentleman. This is another tumor which is I removed from the middle fossa and did lot of vitrectomy at that time. So these are some, I'm trying to show you what I used to do then, and I will show you what I have changed and how I have changed. This was another vitroclaval. You see what a big must have been, I don't remember this case, of course, but must have been difficult and dangerous tumor where I had done such a big vitrectomy and temporal lobe. This is immediate post-operative, and this is another tumor which you can imagine. Now I want to show you, in 2004, I described supracerebellar approach. You see, supracerebellar infratentorial, Sami described for pituitary meningioma retrosigmoid approach like we did for acoustic tumors, retrosigmoid. And we described for the first time supracerebellar infratentorial. And supracerebellar is different, retrosigmoid CP angle approach is different. Supracerebellar approach has its own charm and more beauty. And my feeling is supracerebellar approach, which is now a very popular approach in the field of pituitary meningioma, which we described. And now I have got a huge experience with this, and some cases I will show you. So when you do supracerebellar approach, one thing is you have to have, not always, but you are more comfortable if you are doing in sitting surgical position. If you are doing in lateral or any other park bench or any other thing, you can do it, but the comfort level that sitting position gives you is not there. And you take the dandy vein, cut the dandy vein, retract the cerebellum downward, and you have the whole petroclavicle. I expose this area in 10 minutes. And then you can have the entire. So these tumors, which I used to do entirely from the middle fossa, this tumor is now a clear indication for me to come supracerebral. I expose this tumor, retract the cerebellum down, cut the dandy vein, retract down, and then identify the fifth nerve, dissect between the nerves. So most important issue in any tumor surgery is learn the art of dissection, learn the art of tumor breaking, which you cannot, nobody can learn the art of tumor breaking without breaking the tumor. You have to do the tumor. You have to be in it. You have to go on operating all the time, operating, not just all tumors. All tumors are different. How to break the tumor, how to demolish the tumor, how to get to the base, how to get the vascularity, how to get hemostasis, how to dissect the cranial nerves, how to dissect the fifth nerve, third nerve, sixth nerve, so many. And most important and most critical is how to protect these nerves and how to protect the perforators. Supracerebellar approach is a beautiful option. Now, this kind of tumor, which is right in the CP angle, extending to the pictoclavicle, there is no question. Nobody, of course, will do any middle fossa approach, but still people sometimes like to do pictosectomy and all. But now for me, there is no question. This is clearly a supracerebral. This tumor is like an acoustic. All acoustic we do retrosigmoid. Some people do acoustic also transpetros, and it is not necessary. It is not necessary. You come from here, break the tumor, learn the art of demolishing the tumor. This is, according to me, meningiomas are much more simpler tumors than acoustic. Facial nerve dissection is much more simpler in meningiomas than in acoustic. And this tumor, I will say this tumor should be and can be removed in not more than 20 or 25 minutes. This is another tumor which is going a little bit anterior in the attachment here. This is a very standard meningioma, and there is no need to do pictosectomy. Come from here, identify the tumor, get into the bulk of tumor by isolating the tumor from the cranial nerves, trigeminal nerve, and enter the tumor, break, and then if you just go on coagulating, then probably you will never be able to remove. This is another straightforward tumor. I will say this is one of the much more easier tumor than acoustic. This is another tumor of similar kind. Whether we want to label it as petrous apex, this tumor is a little bit more ahead. But for supracerebellar tumor, this ahead means nothing. You retract the cerebellum down, go. Imagine I used to do pictosectomy for good 3, 4, 5, 6 hours and then reach the tumor. And sometimes these tumors are so soft, then I used to think, why the hell I wasted so much time in this? And sometimes, you have problem here, you have, now here you go, whether it is soft, whether it is firm, you identify the bulk of the tumor, break into the tumor. So this supracerebellar approach, which we described, in my view, is a fantastic approach for the even this. You see, this is going very much ahead. So very much ahead in the vicinity of the midbrain, in the vicinity of the pituitary, break into the tumor, break into the tumor, and you can do a beautiful resection. This tumor, very straightforward. Tumors which go in the, this tumor, you see, when it goes like this, more often it is in the metal scale, not in the cavernous sinus. You see, one, I will tell you another thing. When you are going for pituitary meningioma by supracerebellar approach, dissection in the region of cavernous sinus can sometimes become little tricky because it is away, little away from the field. And if you are particularly operating in sitting position, this can create venous air embolism. So I will suggest don't do too much cavernous sinus dissection when you are coming from the supracerebellar approach in sitting position or in any position. So you dissect when the tumor is in the metal scale. Of course, I cut the tentorium and go here and go there. But in the vicinity of cavernous sinus, you have to be a little bit more careful. So this tumor is essentially going in the metal scale. And these tumors which go into the metal scale are relatively soft. So I operate supracerebellum, retract the cerebellum. You see, you can see those who are experienced can imagine this tumor is soft tumor and goes into the middle fossa, into the cavernous sinus. So supracerebellar approach. And also, it is not always necessary to remove, open the cavernous sinus and go into the, I have a feeling that, you can show a beautiful image. You can show a beautiful preoperative and postoperative image by showing the cavernous sinus and all those things. But you don't think that you are going to cure the person. You just don't aim to cure the person. You aim to relieve the symptoms. You live for tomorrow. You don't live for day after tomorrow or after a month. What will happen to any tumor? Which tumor will recur? Which tumor will not recur? Nobody knows. So cavernous sinus part of the tumor, if it is small, it is hardly causing any symptom. So don't try to mess around with cavernous sinus unnecessarily. So this is a pituitary meningioma, supracerebellar approach. This is another pituitary meningioma going here and supracerebellar approach. So I'm just trying to show what tumors can be removed by supracerebellar. This is another tumor. This is going here. This is tumor, which is a very straightforward tumor and I should not use easy tumor for anything. There is nothing easy in neurosurgery. And to say that this is easy and this is difficult is not a good idea. This tumor having quite a big vascularity from the petrous apex and the posterior wall of cavernous sinus. I did it from retrosigmoid approach, and this was the postoperative. Long time ago, this case. This is another pituitary meningioma. This is tumor going in the cavernous sinus metal scale here, not inside the venous plexus, and this was removed completely by supracerebellar. This tumor, which is going in the middle fossa, in the walls of the cavernous sinus. I don't remember how much, whether some tumor has been left behind or not, but this was also done by retrosigmoid. Tumors which go in the middle fossa, not in the cavernous sinus. This is not going in the cavernous sinus, in the middle fossa. You can come from here, open the tentorium and remove the part in the middle fossa. So this is retrosigmoid supracerebellar approach, retrosigmoid supracerebellar approach. This was another tumor which we removed, retrosigmoid supracerebellar. This is another beautiful case that I did long time ago. This one, and supracerebellar break into the tumor, learn the art of dissecting the tumor from adjoining nerves and vessel. Here there is some residue in the cavernous sinus, quite an extensive tumor here, there, everywhere in the cavernous sinus, in the clivus region, and some residue in the region of, I will not hesitate to say that I have left tumor behind, and I don't feel, I don't regret. And I say that this is what should have been done. and more than that could have been harmful. So these are some tumors which I'm, now this is another tumor, you see vascularity from the posterior part of the petrous bone from the posterior wall of cavernous sinus, and this was beautifully resected. Vascularity, you see how to handle bleeding, how that is our life of neurosurgeon, how to control bleeding, how to go ahead in a bleeding situation. This is another tumor having vascularity from the posterior wall of cavernous sinus, and this is post-operative. This is another very hugely vascular tumor that we removed. And I still remember we have good days, we have bad days, and we have successful days. And if we have successful, then we flaunt in meetings like what I'm showing you. This is pre-op and post-op. This is another tumor, pre-op and post-op. I'm just trying to show you what can be done, and I'm not showing you what complications were there, what can be there, and what cannot be there. Of course, there can be complications, of course, there can be issues, but if there are complications more than frequent, then you should not even touch these tumors. You are not allowed as a surgeon, as a human being, to operate if you are having complications on a regular basis. You will create complications, but if they are happening much too often, then it is not such a great idea. This is another tumor. You see, it is encasing both the vertebral arteries and the entire basilar artery, and this is post-operative. Let me see if I can just show you briefly some images. Unfortunately, yeah, this video is working. Just see the post-operative scenario here, and um, this is the situation after dissecting both the vertebral arteries. This is the fifth nerve, and this is the situation inside, and this is after tumor resection. This is another tumor. The most important issue in petroclival tumors when you are doing supracerebellar approach is the PCOM artery. PCOM artery damage can lead to disastrous clinical outcomes. So there is some, here in this case, there was something stuck to the posterior clinoid. I left, posterior communicating, I must have left behind here. There is some tumor on the clivus. So this is basilar artery. Let me show you quickly the post-operative situation. You see, I'm not a good fan of showing dissection techniques, and I'm not a good fan, and I don't think we should show, because neurosurgery is not showcasing. This is just a kind of a learning process. Sometimes we overdo just to have good images to show our videos, so which is not such a great idea. It may be, this is another tumor, preoperative and postoperative, and you can go down right into the pontomedullary junction. Let me show you what I have to show you. See, this is the basilar artery and the bifurcation. This is the fifth nerve, and this is the sixth nerve. I'm looking down at the pontomedullary junction at the region of basilar artery. You can imagine this is the kind of situation that you can have, and this is the most beautiful, fantastic approach for various kinds of tumors like this one, like this one, like this one, and like this one. So just enjoy these tumors. Here some tumors left behind in the cavernous sinus. I don't mind it. This is a very vascular tumor. And I have to tell you that when the tumor goes medial in the clivus, similar is the approach. When it goes clival meningioma down, it's similar is the approach supracerebellar. And this is this is the case where I just want to show you few terminal parts of the operation. And these are the thing attachment to the petrous apex and where I'm coagulating. And these are the cranial nerves and all those things. These are my very old videos. As I mentioned to you, it is not a trophy to show what you have done. It is the trophy how the patient and your philosophy as to how. This is another tumor. Let me show you what I have to show you. This is the dissection of, this is on the right side. This is the basilar artery. This is after tumor resection. And my style of dissection is different. I have suction in my right hand and my bicep fold on my left hand. This is a unique kind of dissection situation. And I break the tumor with my right hand. I suck the blood with my right hand, and I dissect and retract with my right hand. And this right hand, and with the left hand, I hold and dissect. And bipolar comes in my left hand. So this is a different type of dissection. Now you see this patient comes with sixth nerve weakness. I left some tumor on the sixth nerve. You see some tumor on the sixth nerve, but sixth nerve palsy remains. This is another tumor where I left a lot of tumor on the basilar artery. I don't know why I left, but must be some dissection difficulty. But I am very proud to say that, not proud actually, you must understand what I am trying to say is that if you leave tumor behind, it is not a bad thing, because if you leave 1% of tumor or 10% of tumor or 20% of tumor, the recurrence rates will be similar. Obviously, your aim is to decompress that area. This is another tumor having basilar artery encased and all. I did, this is immediate post-operative. I left quite a bit of tumor, and this is another patient where I left some tumor behind in the cavernous sinus and near the basilar. This is another tumor. This, of course, I've shown you. This is another lady which I recently operated, and she had come. She could not walk before the operation, and she's an oldish lady. She said she does not want. Gradually, her walking diminished. She became drowsy, and all those things. Developed cranial nerve weakness. You see the sixth nerve weakness, and I removed partially. I removed this part of the tumor. I did not remove the cavernous portion. And you see the smile on her face. She came to me with completely intact except for the sixth nerve, which she had before operation, and this sixth nerve. And she's very, very happy on my partial resection. This is another young gentleman. I removed partially and I left quite a bit of tumor in the cavernous sinus in the vicinity of the blood vessels for some reasons which I don't remember. This is another huge tumor where I left some tumor behind. This is another tumor where I must have left some tumor behind here and here. So essentially, my strategy now is that resect the tumor radically. We have to go with the aim of radical tumor resection. Wherever you feel that cranial nerve dissection becomes difficult, or you're spending too much time on the third nerve or too much time on the sixth nerve, leave that part of the dissection. Don't do it. Leave some tumor behind. And if you have to dissect around the perforator for more than 5 minutes, leave, don't dissect, don't showcase your skills. Just to show you a little bit of foramen magnum meningioma. And these are, I described this conventional posterior fossa approach where I do suboccipital craniotomy without doing any vertebral artery mobilization, no condylar resection, working within the cranial nerve, working between the vertebral artery. So this I had described long time ago, and I did several tumors which were going here and there and everywhere, in the midline, beyond midline, here. So this kind of, I am very familiar with this approach and this, but I want to show you some beautiful cases. You see this tumor in front of the brainstem, this tumor encasing the vertebral artery, and you see there is a calcification. This is solid on CT scan. This is a completely ossified tumor, and I removed this tumor. Another tumor, you see this ossification. And ossification, there is vertebral artery between the ossification and a dangerous, difficult little monster here. And this is, and I removed this tumor beautifully by just very, so this was my exposure. This is another tumor. You see, this is an ossified tumor, bone, they're black, and on CT scan, white, and vertebral artery encasement. So one of the most dangerous tumors that you can imagine, but you can, learn the art of breaking soft tumors, learn the art of breaking hard tumors, learn the art of breaking vascular tumors, learn the art of breaking ossified tumors, and try to work within the, I reported this ossified anterior foramen magnum meningioma, and of course, I have done for pictoclaval, chordomas, and all those things. This is one of middle fossa approach where I use for pictoclaval. You see, this is very old operation of mine where I'm mobilizing the carotid, mobilizing. You see, this is the carotid. These are the fifth nerve and various things, and working on the clivus, breaking the clivus, going into this. So this has been my life, and this has been a beauty of my life, which I have enjoyed. And recently, I have describe the supracerebellar approach for clival. This tumor can be approached from the nose. This tumor can be approached from the middle fossa. But the sixth nerve is displaced on the other side. And these are extradural tumors. So we describe supracerebellar approach to these tumors, which is a beauty. This is another clavicle. This is another clavicle. You can come from the nose, but the sixth nerve will come last. So identify the sixth nerve early in the operation and ram into the tumor supracerebellar approach. For meningiomas, tumors which are difficult to remove are inherently aggressive in nature. Most important, recurrence of these tumor is related more to aggressive nature of the tumor rather than, you see, this sentence is very, very important. And if I have to give one message to young people watching me, listen to this message. Recurrence in these cases is related more to the nature of the tumor than to incomplete resection. Easier tumors, well-defined, good arachnoid dissection are more benign in nature. Tumors that involve cavernous sinus are inherently aggressive. Cavernous sinus meningiomas that involve the paranasal sinuses are malignant in nature. Tumor resection at the cost of neurological deficit is a failed operation. It's not a good operation. You must also, beautiful sentence I am giving you. Once a meningioma, always a meningioma. All meningiomas are classified into two broad groups, good or bad. You see, we say after 5 years of surgery, oh, this was a good meningioma, it has not recurred. And we say after 3 months of surgery, this was a bad meningioma, it has recurred. So we can identify good or bad only by hindsight, not beforehand. So, and of course, by some imaging characteristic, edema and all those things, we can identify, but essentially by hindsight. It is not the treatment, but cellular behavior that decides the outcome. Beautiful sentence for you. Recurrence of tumor does not depend on radicality or extent of tumor resection. Every neurosurgeon must have a plaque in front of clinic stating there are some patients whom we cannot help. There are none whom we cannot help. So we have to be very philosophical to be conscious that you are ignorant is a great step towards knowledge. If you are restrained in your approach, you are less likely to disturb. Resect the meningioma radically. Patient should improve in the symptom. If symptom recurrence, then reoperate. Role of radiotherapy is a little bit controversial. Avoid it, because if you give prematurely, the recurrent reoperation can be difficult. So that is my message to all of you. Thank you very much, my dear friends. Thank you, Noor, for inviting me, and I'm happy to be on your show. Thank you very much.
Thank you so much, sir. It's an honor for me, basically, to have you here. Let me see why my camera is not working. Sir, I'm so happy to say that Professor Vladimir Benz is with us. It's an honor to have Professor Vladimir with us. Hello, sir.
Hello. Hello. The pleasure as
Hello, sir.
always, Atul.
My dear Vlad, it is my great pleasure
Hi.
to see your face. And you must know
Mine
that
too.
Vlad is
Yeah.
my friend and my senior brother for a long time. He has been associated with me, and we have walked this path of neurosurgery together. Of course, he's senior to me. I respect him like my older brother, and he loves me, and we have mutual respect. And Vlad, what is your good comment? Tell me, Vlad.
Thanks, Atul. Could I comment?
Yes, Vlad.
Yes.
Yeah. Atul, you didn't mention sectioning the tentorium. I do
I
it almost in all the cases.
I actually mentioned, Vlad, you may not have joined earlier. In
I
1995,
see.
in the earlier part of my talk, I talked about how to section the tentorium and how to make a cut. Actually, I described a technique of dissection of tentorium in 1995. I make a cut on the edge of the tentorium and retract it like a flap. So identify the
Right.
fourth nerve, make a cut not near the apex, beyond the apex, much beyond the apex, identify the fourth nerve, and then retract and cut the tentorium as a flap. So this is what I described long time ago, and that
Yeah.
was published in British Journal of Neurosurgery. I showed it, blood,
I,
you probably missed it.
I know the work. I joined a little later, so you probably mentioned that before. Then another remark. Once you section the tentorium, you get above and in front of the tumor, and you very early on see the interface between the brainstem and the tumor, which is of big advantage in my mind. And
Yes.
what I do sometimes that I drill off the Petros apex. Do you do the same?
You see, you know what, blood? What I have now realized from the posterior fossa, going in the middle fossa for part of the tumor which is in the cavernous sinus. I'm not saying part in the middle fossa that you can remove by tentorium sectioning and tentorium flap and going up. That is all right, middle fossa part. But the part which is going in the cavernous sinus is a little bit dangerous to remove because many of my cases I do in sitting position. And that venous bleeding which happens because of experience in one patient where I had got a bad venous embolism, air embolism, I
Uh-huh.
hesitate to work in the cavernous sinus from the posterior fossa and drill the petrous apex and to remove like even Mario Tatagiba talks about it going from the from the posterior fossa and drilling. I little bit blood I hesitate to go into the cavernous sinus from the posterior fossa unless it is in the Meckel's cave. In the Meckel's cave, of
Right.
course, you can follow the tumor and that tumor comes out. If it is in the middle fossa, you can get the tumor. But when it is in the confines of the cavernous sinus, if you saw many of my pictures, I left a lot. In many of my cases, I have left tumor behind in the cavernous sinus in a number of cases because I hesitate to operate. And if it is a largest tumor, I like to go in a second stage in the by a middle fossa approach, if necessary.
Yeah. I'm leaving always cavern. I do not enter cavernous sinus from posterior. I always leave a piece behind since there's radiosurgery, no doubt about that. The next question, Atul. Once the tumor is anteriorly, the first thing in front of you is the fourth nerve, and
Yes.
that's very difficult to handle. Any trick?
See, fourth nerve, you know what, blood. In one patient, one very important VIP kind of patient, I removed the tumor beautifully and I cut the fourth nerve. But the tumor was all right, patient was all right, moving hands, legs, and all those things. But she kept on complaining about double vision and eye. She was never happy with the operation. So fourth nerve is so important and so critical that we have to give all attempts to save the fourth nerve. Of course, sixth nerve is very critical in petroclival meningiomas. Fourth nerve is also such an important nerve. It is usually along the edge of the tentorium. And when you're going supracerebellar, you try to work on the proximal dome of the tumor, enter downwards towards the sixth nerve before you go towards the edge of the tentorium, because that part edge of the tentorium is little bit more tricky because the posterior communicating artery and the third nerve also are in that area, which can get, you devolve the tumor a little bit away from the tentorial edge downwards in the initial. That may just be one point, but we all tumors are different. We have to have our own way for every case. But as you very rightly pointed out, that the fourth nerve is such a critical nerve, we cannot neglect that nerve just because eye movements, lateral movements, medial movements may be normal, but the patient can be very badly disturbed by fourth nerve deficit, and we have to preserve
You shouldn't allow the patients going downstairs
it.
because then they have the double vision. And the last question, Huda, can
Yeah,
I,
yeah,
Maria,
please,
one more?
sir,
Yeah.
because it was
Uh,
my pleasure to have you here, sir. Thank you so much for joining us. It's amazing that we have got the privilege of listening to both of you because both of you are the masters of skull base. So thank you, please,
no,
sir.
no, Atul is a master. I will, I just follow him. Uh, Atul, the true posterior clinoid meningioma is pointing upwards.
Yeah,
But by nature, this is the posterior fossa tumor. Once
yeah.
you approach it from anterior, you have all the major vessels, all the perforators in front of you, and the tumor is behind. It would be logical to approach such a tumor via suprainfracerebral approach as well. Did you try something like that?
You know what, Vlad, this is a very, the posterior clinoid meningiomas are difficult tumors, and as you rightly pointed out, they are dangerous tumors. And more importantly, the third nerve is in a big proximity to these posterior clinoid meningiomas, and you can damage the third nerve. Posterior clinoid meningioma to come from supracerebellar infertentorial approach, they become a little distant. They become, the distance from the surface becomes a little, sometimes too much. And if the tumor is going more up, it may be better to come from a terional approach, and basal terional approach may be a better option rather than coming from supracerebellar approach, because sometimes the distance becomes too much, and the control of posterior communicating artery, as posterior communicating artery is so important in pictoclival meningiomas when we are operating from this approach, because that artery, one perforator you damage, you can create, as you know, blood. We damage one perforator, we can have hemiplegia at hand. And that is such a great and huge complication. So it is better for largest posterior clinoid meningioma to come from basal terium.
Right. Did you cut tentorium in that case, posterior to the fourth?
That will, of course, obviously depend on how the tumor extension is there. But if it is going down, then you have to cut the tentorium. And I wish, Vlad, you had seen my tentorial flap, which I showed here. And maybe I send you that article on your mail.
Yeah, good. Okay. Thank you.
Thank you, Vlad,
So,
for
uh,
attending this.
Thank you,
sir, since
Atul.
we have got both of you here, sir, I wish to know what are your views regarding the endoscopic transclavial approach for petroclival meningiomas?
What approach?
Endoscopic.
Now, you know what? I have talked about it on several occasions, and Vlad is also here. And let me see how he has to respond. But my response is very clear. Meningiomas are cranial surgery. Meningiomas, whether it is tuberculum celli meningioma, whether it is claval meningioma, whether it is foramen magnum meningioma, you come from the nose, you are, taking big risks of working in a remote place. You see, from the nose, the clavus is so far away. You dissect the vessels, and some tumors are soft. You can do from any approach. But these approach have been standardized. Skull-based surgery has born and been brought up and has advanced tremendously over years. I don't believe that any endoscopic approach should be done. We can do it, does not mean we should do it. What is important is whether we are able to do it is not the question. We can do whatever we have to do, but whether we should do or not, answer to your question is we should not ever do it. I want to have Vlad's opinion also. Vlad.
I fully agree with you. When the technique was new, we tried several tuberculum meningiomas and we quit. We reverted back to open surgery, and I believe that meningiomas are not the target for endoscopic endonasal. There are other diseases which should be treated by this approach, but not meningiomas.
Sir, there's also another
Uh,
question in my mind. Do you think that what will be your, like, how much aggressive your approach will be if you are actually expecting that this tumor is atypical meningioma, it is more aggressive? How aggressive will you go? And how much would you like to leave behind and just go to wait and see policy or do opt for stereotactic radiosurgery? So how the behavior of the tumor, your predicted behavior, what will be your approach in that way, and how much aggressive you will be?
You know what? Neurosurgery is a huge subject. Neurosurgery is a very massive subject. And when we decide on how much to remove, there are so many things under consideration, like patient's age, presenting symptoms, extension of the tumor, vascularity of the tumor, nature of the tumor, location of the tumor, how much to remove, how much can be removed. You see, it depends on your experience and your understanding. As my first slide showed, philosophy is important. Understanding what we are going to do and what we are leading to is so important and critical in our subject of neurosurgery. So every tumor has different kind of strategy, and every tumor, the scope is different, the intent is different, and the outcome is different.
That's true. I guess Tate Matheson did long-term follow-up in meningiomas, and he found out that they had the same prognosis as breast cancer, like 80% alive and well after 10 years. And this is something we must accept, that there are meningiomas which we are unable to treat or unable to cure.
Yes, yes. So that is another very important thing that, meningioma, you cannot ever go to say that I am curing a meningioma. I am going to cure because I have removed it completely, I cure. This is not you can never cure a meningioma. Once a meningioma, always a meningioma. If you have removed it completely, you have left 1% behind or 10% behind. You cannot remove your potential of making a meningioma. Once a meningioma, always a meningioma. You cannot remove this potential ever. So you go safely. Most important in neurosurgery is safe, surely, definitely. And there is no hesitation to show that you have not removed it completely, you have left behind. It is a good thing to show that you have kept the patient safe and kept them, and because recurrence is not in your hand.
Exactly, sir. So this is a very insightful talk, sir. So there's also I think a couple of questions here again, sir. I think this is the question about again the residual. Um, there are so many compliments for both of you, Professor Atul Goel and Professor Vladimir Benz. Everyone is so much in awe to see both of you together here. So there are so many compliments for both of you. And what a wonderful talk, sir. Please, when it gets to a point, so there is a question over here. It reads, cannot actually express it. What a wonderful presentation there from Professor Atul Goel. Thank you very much. Please, when it gets to a point where you leave behind some tumor behind, does it mean at that point there is no way at all you can get all the tumor excised? And when you leave some behind, how do you follow up the patient subsequently? Because I believe the leftover tumor with the time will grow gradually as it is still going to get some blood supply. Thank you very much. I need your attention here. Okay, sir.
If you have left some tumor behind,
Yes.
then the only thing is just put your hands up and pray to God that
Yes.
it should not recur. And wait for recurrence. If it recurs and if there is a symptomatic recurrence, then go again. Means you use knife again rather than using gamma knife in the first place. So surgical knife is more important. But when you think that your surgical knife can be dangerous, when you think that surgical knife is not such a great idea, when you think that surgical knife can create a deficit, that is the point where another stereotactic radiation or other kinds of radiation will come in picture, not beforehand. It is for a surgeon to decide whether he can safely remove the residue, and otherwise he can just leave the residue and wait for recurrence. Recurrence will occur. Meningiomas are tumors. All tumors can recur, whether they are benign or whether they are aggressive or whether they are malignant. Every tumor can recur, but many tumors don't recur. So we cannot predict which tumor will recur. If they recur, then we see what happens.
And so there's also a question that if tumor is abetting the basilar artery and infiltrating the perforators, then how would you actually go for the amount of resection of that tumor? Because obviously, there are certain points that if it's going all over there, obviously you have to leave the residual. So how much would you what will be your approach there?
No, basilar artery, we can show our technique of dissection. We can show
Yes.
our style of dissection. We can show our surgical technique and make a beautiful video out of it and show in meetings and flaunt like your medal. But you must remember, in an attempt to dissect, of course, we have to dissect. We cannot go for a conservative resection. Always, when we plan an operation, we go for radical resection.
Yes.
We go with the aim to remove the tumor completely. We go with the aim to remove the tumor radically. But wherever we think that our radical resection does not seem to be very safe, we should be conservative in that area, like in the region of perforator, because in the attempt to dissect and show our dissection. If we suppose damage, you have a hemiplegic patient or a dead patient. So you cannot create. You see, at that time it is not here. It is in your head. It is in your understanding. If you can dissect, of course you can dissect. And if you are not going to dissect, then why you take the patient? You should not. If you don't know how to dissect, then you should not do the operation. But we have to also be human beings and safe human beings.
Exactly. So,
Well,
there's also
once
some. Yes, sir.
can I say something to the
Yes.
partial resections? Uh, there are two things I would like to mention. First thing is that once you see on MR a black line going to the vessel, that's within the tumor. And the vessel may be completely encased, but the black line is there. Those are the sheets of arachnoid. And then you can get around and resect the tumor completely. If you do not see this black line, if you do not find it, then the vessel is really encased. And for instance, in anterior clinoid, if it's in the cavum, it's not covered by the arachnoid. And then there is the danger. And against the brainstem, once you see first thing edema in the brainstem, you may shoot at the partial resection because there will not be sufficient interface. And once you decide for partial resection, it's better to leave a little larger amount of tumor there, exactly as Atul has shown on one of his images, such a half moon going on the brainstem. Because if you really get to the surface of the tumor and you are coagulating, then you would coagulate also the perforators, which are just on the opposite side of the tumor capsule, let's call it like that. So it's better to leave a little larger piece behind. And what's my experience that quite a lot of these left behind tumors do not grow at all. They are stable for years and you just follow the patient. So it's not a shame to leave a piece behind. But sure, you shoot for Simpson one in all cases.
That should be an ideal thing that could be if possible. Sir, there's also a question regarding the approach selection, like in many of the classical literature. It is, we have discussed a lot about the anterior and the posterior petrosal approaches. So people really wish to know what is your take, both of you, regarding the anterior and the posterior petrosal approaches.
The approach dissection, approach selection is the key issue in petroclival meningiomas or for any meningioma. How much bone you will remove, how much dura you will open, how you will retract the brain, how you will identify how vascular is the tumor, how much blood you need for your surgery, how much exposure you need for your tumor resection, where you will go first, how you will dissect the base, how you will get that exposure, how you will then dissect the vertebral artery or basilar artery or carotid artery, how you will dissect all these things come in your planning of operation. You have to plan the surgery. You have to plan your strategy. And that planning, you see, when I was a younger boy, I used to plan for the whole night. Whole night, I used to keep on thinking, this will be my approach, this will be my, how this is the way I am going to expose, this is the way I am going to dissect, this will be the way I will find the brain. Of course, what you think does not always fall in line, but you have to plan before operation in the night time. And I used to, continuously, whole night, I used to just think about one case. I used to see the images for hours and hours. Where is the tumor? How is the tumor? And you have to learn all these things and you have to grow with it. And more importantly, you have to be in it. You cannot remove one petroclival meningioma in 1 year. You have to remove many petroclival meningiomas and many difficult tumors on a continuous basis. So more you operate, more your experience, more your comfort level, and more your beautiful is your outcome. And more strategic is your approach. Earlier, as I mentioned, my exposures were very big and huge. I used to mobilize the carotid, mobilize the facial, drill the petrous bone in hundreds of cases. But then as I grew up and I became more, as I understood these tumors better, as I understood the quality of these tumors, the consistency of these tumors, the vascularity of these tumors, my exposures have become much less during the period. My surgical resection may have increased over the period. More important is, as I become more and more experienced, I think there is no question the safety of operation has also increased. But I must again say that these games are difficult games, these games are dangerous games, and you have to be prepared. If there is a complication, you have to learn to handle the complication. You have to learn to adapt to that complication. You should not get disturbed and you should not start, breaking your head over that complication. You have to learn from that complication and you have to grow in your stature and in your experience and in your work. So this is a learning process.
Exactly,
Fully
sir.
agree. I have just general remark, make surgery as routine as possible and as simple as possible. Compared to 6 hours petrosectomy, 20 minutes supracerebral infraventral, that's the difference. And then make it like a battle. First, surround the enemy. It means going all along the tumor with keeping the arachnoid plane. Cut the enemy supply lines. It means go for the tumor origin. Then decrease the size of the tumor, which is in Atul's terms, demolish the tumor. Then clean the last pockets of resistance. And last point is reconstruct the territory.
This is basically all your experiences, which is like impeccable experience of both of you, and that's why we consider you the master, and we just look upward to you to learn more about it. And I totally agree with all this. So there is a very special message for Professor Atul Goel by Dr. Hamid Damaran. Sir, you are the king of the hearts. Thank you very much for your great knowledge you give us all the time.
Thank you very much. Thank
Hello,
you.
hello, sir. Do I have some comment? Hello,
Yes.
Yeah, Yang
hello,
Dong.
hello, hello, hello.
Yes.
Good night. Hello, dear Professor Abdul. Thank you for your beautiful lecture again. Today you have talked so many about the supracerebral approach. And near 10 years ago, when I was still a medical student, I read your article describing the supracerebral approach for petroclival meningioma. At that time, I believe it was incredible. It was impossible. And 2 years ago, in 2023, you have conducted a lab surgery workshop, and you have shown us a case of petroclival meningioma. You finished the operation within 1 hour from skin incision to dural closure. It was another incredible, but it really happens. And for me, I think, in my opinion, I think the supracerebral approach is a very beautiful approach to the medial temporal region, thalamus, brainstem, and the petroclival region. Just 3 weeks ago, I just 3 weeks ago, I just finished a case of midbrain cavernous malformation. To be honest, it was the first time I do the operation in the posterior fossa independently. The pity is that I exposed the ambient system within 20 minutes, maybe 15 minutes longer than you, but the result is quite good. And so far I have no case of petroclival meningioma, but I think I am ready for this formidable disease. And thank you again for your beautiful concept. Thank you, sir. And also today we are very happy to have Professor Vladimir here. Everybody knows he is another giant neurosurgeon in supracerebral approach. So thank you, Professor Vladimir. Thank you.
Thank you. Thank you. Pleasure.
Professor Vladimir, I really wish to invite you to another talk. I remember holding a wonderful webinar with you previously, like a year ago, with Professor Luis Borba in attendance. It was an amazing webinar, and it is still being seen by many of people because I have kept the recording. I can see that many people listen to that webinar, go over and over again, and listen to what you have said. So again, thank you so much for joining in. And there is another message for both of you, Dr. Thompson Silva. there's a special thanks to Professor Atul and Professor Vladimir Bent. I'm so happy learning from both of you and from your wide experiences and knowledge. It helps a lot back in Cameroon and the sub-Saharan Africa. So it really matters that your voice is being echoed over the world, especially in those areas where the training level is not that much of good. And I think that what you are doing is changing the world of neurosurgery.
Thank you very
So
much.
there is a message from Dr. Muhammad Al-Mazougi. He's saying the art and philosophy of breaking the tumor is what changed my life. Thank you very much. I'm Muhammad from Libya. Thanks a million.
Thank you, thank you, thank you, everybody, and best wishes to all of you. Let's do it and let's progress. And my best wishes to all of you. Okay, Noor?
Thank you very, very much. So, just a last thing. I've taken so much of your time, but John Bennett wants to say hi. Just final thing. Sir, thank you very, very much. But he really wished to say hi.
The king has
My
spoken.
pleasure.
Okay, John.
John, how are you?
Good to see you, Atul.
Thank you, John. Vlad is here. John, did you see him?
Yes, I saw part of it.
No.
I had a
Hello,
competing
John.
web.
How are...
It was a mistake to have a competing webcast against you.
I was trying to join this webinar and it was so difficult. So I came late, some like 10 minutes. So I missed probably the best beginnings of Atul's speech. Good.
Sir, it was an honor and a pleasure, and I was so much happy to see that Professor Vladimir Benz joined us, which added much, another aspect. So thank you very, 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 very much for joining us today. It was an amazing session. I have taken a lot of time from both of you on a Sunday, and I can just totally, I can understand that it has been a real honor. Thank you very much to both of you for sparing your time and for your amazing lecture and for sharing your view again. So I think it is time to wrap up this session, and I'm looking forward to the next webinar of the series, and also looking forward to inviting Professor Vladimir Benz next time.
Thank you very much. Bye-bye. Bye-bye.
Thank you. Bye.
Thank you very much. Bye-bye.
Bye.
Bye.
Dr. Yendong. Dr. Yendong.
Almost the end.
Hello, Dr. Yendong.
Hello, John.
Hey, listen, I just want to tell you, you can televise any of our webcasts on China.
Yeah, definitely.
You don't have to ask me. You have permission to take any of them. Okay.
I search your website every day, and I try to televise every webcast.
Yeah, you're welcome. You're welcome to. Because sometimes I want to tell you you have permission, but you probably already do it anyway. So, like James Leo and the webcasts like that, you're welcome to take any of them.
Definitely, yeah. Okay, no problem.
Great. Thank you.
Thank you, John. Thank you.
Bye-bye.
See you.
Bye.
Thanks, Noah.
Bye.
Hi.